I'd like to introduce our next speaker, and I want to make sure I have the order correct. Dr. Terry Melvin is a board-certified geriatric medical specialist. She works in Chattanooga. She states that she's been here over 37 years, so that means she must have went to medical school when she was 10. She's a experienced, dedicated primary care provider in geriatric medicine for this region. She's a certified medical director for hospice and the fellow of American Academy of Hospice and Palliative Medicine. She received her Bachelor of Science in Chemistry and Biology from Texas Southern University, her doctorate in medicine at Tufts, and her internship and residency in Baylor Medical College. She is going to be talking about on the front line and how primary care people look at defining PAD. Dr. Melvin.
Hey, good morning. So the pictures that we see are what we don't want. And so I think our goal is to look at approaches and how to be aware and acknowledge that peripheral artery disease is existing in the patients that we see. It was originally discovered in the veterinary medicine when a horse was lamed, and when they did some studies, found that posterior limb, the femoral artery was clotted. And so this idea of claudication has been around for a while, yet in our patients, it seems like we haven't caught up. So in humans, it was first noted by Brody in 1884, and then Charcot in 1858 clearly defined the whole syndrome of intermittent claudication. We've gone through some of the prevalence. I'm going to just breeze through that. As we get older, we have an increased risk. It affects 1 in 8. Atherosclerosis is a panvascular process, and so I think leaving here, I want that to be something that we be thinking about. It is early recognized and treated can reduce risk, critical risk. Endovascular strategies, rival long-standing surgical paradigm for revascularization, and PAD is underappreciated. We talk about nationwide. We see that 202 million people in the world are affected. And between the 2000 and 2016, there was an increased risk. I like this slide because it talks about when we think about claudication or ischemic limb disease, we sometimes don't really take into thought that it is going to affect the whole body. With the claudication, we commonly see this proximal atherosclerosis in smokers, and with the limb ischemia, we see this mainly with diabetes, because it's a distal microvascular small vessel disease. And I think that there's a lot more about this limb ischemia that we'll talk about a little bit later. The major risk factors, the number one is smoking. diabetes, hypertension, and then elevated cholesterol. Some of the presentations, they can have pain on movement, resolves at rest, leg pain, aching, fatigue when exercising. The pain at rest is something that we haven't really been thinking about, and that is people are up on their feet all day long. They lay down in the bed, and they have to get up and walk again. And so it's hard to differentiate, is that restless leg? Is that cramps? What is that? And I think we have to have that on our radar screen, that it could be pain or paresthesis from decreased blood flow. So they're up on their feet all day, they have the pressure, it's pressing through the atherosclerotic plaque, they lay down at night, they put their legs up, they have more pain. We sometimes miss the atherosclerotic process. I'm getting ahead of myself, I think, but when we look at peripheral artery disease, we want to look at the feet. There could be decreased or absent pulses, color changes, the rhubarb, the nails can be thick yellow, or they may not be any growth. The legs and foot are cooler compared to the other parts of the body. You could have vascular bruise in other parts of the body, such as in the groin and in the carotids. And then they have the non-healing wounds. In our practice, the first thing we do when we examine a patient or when a patient comes in is we take off their shoes and their socks. We don't start at the head, we start at the foot, because the foot can tell us so much about that patient and what's going on with them. You know, and taking off a foot and a nail comes off, and I can tell you sometimes it's pretty gross, but that's where we start. In our geriatric patients, a lot of times they're having problems walking because they haven't cut their nails. They'll literally have nails growing into their skin, and we take the time to do that. We look at their nails. We look to see if there's hair growth on the foot. We feel under the bottom of their foot and heel to see if there's any calluses, and then we take a peek at the calluses. Because sometimes you have calluses and there's blisters underneath the callus. Or the patients have tried to shave the callus, and now they have a secondary wound that they probably don't know. If they can't get down to cut the nails, then they don't know what's happening underneath their foot. Then we'll check the pulses, and sometimes we have to use a Doppler to make sure that those pulses are there. So one of the key elements in establishing the diagnosis is the history, and I think the most important history part is your foot exam. And then listening to bruise in the carotid as well as in your inguinal area. So that's part of your physical exam. Then you have a non-invasive assessment, and then you have the invasive. Sometimes we misinterpret this presentation of ischemia or pain for disc disease or osteoarthritis of the hip. Commonly is spinal stenosis, diabetic peripheral neuropathy. They have diabetes, they have pain, oh, it's neuropathy. Or some kind of deconditioning with the muscle. The most common ones we see is your disc disease, arthritis of the hip, and the neuropathy. So just because someone has diabetes, don't assume that they have peripheral neuropathy. I think we really need to rule out the fact that they have atherosclerotic. There's a possibility of atherosclerotic processes that are being developed. So the diagnostic, I'm sure they're going to go through this a lot more in detail. I think my one takeaway message is to make the diagnosis, to do an ankle brachial index test. It's simple, it's painless, it's accurate, and it's highly reproducible. I think, does that say reproductive? That's wrong. It's reproducible. We just want you to do it every time. Okay? And so how do you do it? And we do it in our office. It gets real technical, but simply we check the blood pressure in the ankle, and we check the blood pressure in the arm, and we take the systolic ankle over the systolic brachial, and we've discussed this. It's 95% sensitive, 98% specific for PAD, but the question is, how often are we doing this? How often do we look at it? It's real simple. I had a student that came, was shadowing, and I asked her what the ankle brachial index was on this patient, and she didn't know. So we explained it, and she goes, I work in cardiology, we don't know this. And I said, well, now you do. So I think it's something that we can do real easily in the home, at the bedside, in the office. In preparing for this, I looked back at some previous studies, and I'm not really a study graph pie guru, so I kind of simplified it so that it made sense to me, and we hope it's going to make sense to you. So with medical trials for patients with MACE, major adverse cardiac events, the trial of medical therapies in patients with PAD goes back as far as 1990 and moving forward. A few things I just want to point out. There really has never been any limb benefit. There's no difference in amputation, but in 2000 with the HOPE, it was discovered that using the ACE did help patients with atherosclerotic disease, and those patients with hypertension benefited. Moving up to the HPS is when statins were involved, and now we're using statins more and more. The dual antiplatelet therapy, up until just recently, had sort of been mainstay. I'm not watching glazed eyes, am I? Are you glazed? No. Okay. And with the Euclid, it was actually a PAD study that supported and showed that you really can't treat PAD and limb ischemia as you would CAD, and that if somebody had prior revascularization, it was associated with a long-term risk of acute limb ischemia. So we want to look at this, and we want to approach peripheral artery disease before we get to this. They also found that patients with diabetes, that the majority of amputation was related to infection. And I think when we look at peripheral artery disease in patients with diabetes, we may be looking at kind of a different animal. And I say that, and I also say that in my geriatric population, those patients that are amputated, it's secondary to infection. And so I'm not really sure what that means. Let's see. They're assuming that all PAD patients have CAD, but only a third of them are symptomatic. And those patients with PAD that die, 71% will die from a non-cardiac cardiovascular event. And that non-cardiovascular event may be an aortic aneurysm, maybe infection, maybe heart failure, okay? So I like to think about limb ischemia or claudication, peripheral artery disease in the leg, as a non-STEMI in the leg. If you have ischemia, PAD, Think about it as a non-STEMI for the leg. It's like the first knock-knock sign, something's going on. And I think Chris alluded to this already, but PAD is a worse outcome than breast cancer and Hodgkin's lymphoma, and it's just behind colorectal cancer, which is on the rise. So when we look at treatment, if you don't like doing foot exams, and they're not always the most pleasant, I think we need to have our patients set up with somebody where they will get regular foot exams. Every time a patient comes in our office, we look at their feet. It's to the point where I go in and the men already have their shoes and socks off, and they go, "I'm ready for you today." I'm like, thank God. I think exercise, cardiac rehab. So recently CMS has just approved, and I'll go through about the supervised exercise. And so that's something that I don't think we've thought about before. We need to be thinking about it. This is really hard, this whole smoking cessation. The person has got to want to stop smoking. If they don't want to stop smoking, it's, it's up to them. I've gone through and go, take your cigarettes and break them in half and just take a few puffs, and, they got to want to do it. And I don't know how to make somebody want to do something. I often say, you're good today. How you are today, you're fine. But I don't care about today. What I'm worried about is how you're going to be in 10 years and 15 years. And then I try to tie that with what is going on in their life. So do you want to see your grandson graduate, or do you want to see your son get married? Because I think that's crucial. It kind of hits a nerve. High doses of statin, and the high doses of statin are those same doses that you would give in cardiovascular disease. You want your blood pressure below 130 or 120 using an ACE and beta blocker, aggressive treatment for diabetes, and then antiplatelet therapy. So the Voyagers, I guess there'll be somebody speaking about this today, but this is like our new latest and greatest to help with acute limb ischemia. It was shown to be a game changer in MI and ischemic stroke. And I'm not going to go through the details on this, but it's using low doses of the rivaroxaban in patients that are at risk. So some indications for revascularization would be critical limb ischemia, so progressive pain, pulselessness, pallor, paresthesis, paralysis. That's what that says. Disabling claudication, and this can be subjective. And then this whole thing of the quality of life. I think the goals of care, shared decision-making with the patient, the likelihood of doable benefits. We have to really sit down and have a discussion with the patient. We want to be like Ed, where we're on the front end of it instead of being in crisis mode when we're like having to do something to try to save the limb. And I think that's the whole purpose of this today. So some of the medications for revascularization. Has been, the one on my left, probably your right, has been shown to inhibit platelet aggregation and is effective when used to earlier on with helping patients to start their supervised walk program, because it has been shown to pain-free walking distance. There is a black box warning, and it's contraindicated with congestive heart failure. The fentoxifilline hasn't really been shown to cause or be helpful for vasodilatation, peripheral vasodilatation, but in some patients, it has been shown to have some pain relief. I think I last wrote for this maybe a couple years ago. I haven't done it recently, but I just didn't want to throw that baby out with the bathwater. So when we look at this, we have antiplatelet therapy, cholesterol-lowering statins, ACE and beta blockers. There's a reduction of symptoms. We want to use the exercise, cilostrozole, catheter-based interventions, and then reconstructive surgery. So let's talk a little bit about the exercise. So some studies have been done, and it looks like 30 minutes, 3 times a week, is you'll get your bang for your buck. If you do more, and these are people with documented atherosclerosis, ischemic changes in their legs to help improve with revascularization and blood flow. A minimum of 3 months, and the goal was to reduce claudication. So there's been some studies looking at supervised exercise versus exercising on your own, and the supervised exercise was more beneficial. The CMS now pays for cardiovascular exercise in this situation. There was the CLEVER and the ERASE studies that looked at, the CLEVER studies was exercise versus stenting, optimal medical care, supervised exercise, versus just stenting and supervised exercise. And the study actually closed because it was not enough people enrolled. So then ERASE came up with another study, and the question is, people that start with the exercise, if the pain is really severe, stenting and then exercising compared to just exercising. Initially, with the stented group, they had more pain-free, but at the end of the study, which was at the end of a year, they both did the same. The outcome was the same in terms of exercise distance and pain relief. So in summary, I think it's important to be aware and make the diagnosis of PAD. I think the goal is saving the limb. And the treatment is going to be your medications. So there's been studies looking at claudication, peripheral artery disease, and we're really not using our maximum medicines that we could be. They're not on the high doses of statins. They don't have tight blood pressure or blood sugar controls. We haven't talked about stopping smoking. They haven't been on a trial of supervised exercise, and then whenever indicated, the blood thinner. Then we go to stenting and then surgery. So I think that more studies are probably needed to be done in the peripheral artery disease. There is still some disparities of care that needs to be addressed. I think patients with diabetes and the few that I've had in my geriatric population, death is occurring as a result of infection. I'm not sure what that means. And I think that's all I want to say. So I think you want to think about that atherosclerosis anywhere is atherosclerosis everywhere. So they may not be symptomatic, but if you have a house and you have rust in your pipes in the basement, you're probably going to have rust in your pipes in the attic. So we got to, thank you.
All right, so this session is to diagnose PAD in the primary care and then work it up. And the workup for this is usually non-invasive if we can do that. That's the first type of workup. And we want to have a workup that's cost-effective. And I'm pleased to introduce Tina Creek. She's an RVT. When I went on my own as a private practice doctor, I needed a nurse, and I needed an ultrasound tech, and I needed to have the tech that understood how things work. And Tina Creek has been our technical director at VIC for 6 years. She's probably 25 years experience and one of the most experienced techs in this region. And she covers our four areas. She's a certified RVT adjunct instructor at Chattanooga State for ultrasound, vascular ultrasound. And I give you Tina Creek.
Got it. Thank you. Thank you. Good morning. So I get to talk about one of my favorite subjects today, and that's vascular ultrasound. So the modern non-invasive vascular workup of the lower extremity circulation. So when you talk about the very beginning, the reason for the referral, sometimes we get it for leg pain, wounds, swelling of the legs. But the key to a good vascular workup is asking the right questions. So how do you determine what's going on? Is it arterial or venous? They can have similar symptoms. They both can present with non-healing wounds of their extremities. They both can have symptoms of claudication, but there's a difference between the two. Arterial claudication is described mostly by the patients as achy, fatigued, tired feeling in their legs. They can't walk from the front of Walmart to the back of Walmart without hanging onto the buggy. And it's usually relieved with rest and defined to a certain muscle group. They have pain in their calf when they walk, or pain in their buttock or their hip. Venous claudication is usually patients describe as a bursting type pain, and it affects the entire leg, where arterial claudication is relieved usually with rest. Venous claudication, the patients usually only get relief by elevating their legs. They both can present with decreased pulses. Arterial, because they have a lack of blood flow in their extremity. Venous, oftentimes these patients have swelling to massive swelling, edema, and it makes it difficult to palpate those pulses. So what do we do with these patients? Well, you can see here they all can have wounds that present differently. You have an arterial wound, usually on the digits, pallor of the foot. We've talked about, Dr. Melvin talked about always looking at the patient's foot. Venous wounds can usually present in the gaiter area. I used that term recently in the lab, and some of the younger techs looked at me like they had no idea what I was talking about, but it must be an old term for techs who've used it for 25 years. But anyway, it's the area between the ankle and in the calf. And so that's where you most often find those venous type wounds. And then you can have those patients who have mixed arterial and venous wounds. So how do you figure that out? Well, we're going to stick with the theme of this session of the morning, and that's PAD, right? Damage, defect, or blockage in the artery. How do we get the provider the necessary information to treat the patient regards to this. So why is it important? Dr. Lassar talked about this early in this morning about early PAD is oftentimes asymptomatic, but why do we need to catch it early? It reduces the risk of ischemia, which can lead to unnecessary amputations, and that's what we're about, preventing amputation. It's a marker for atherosclerosis in other organs. We've talked about that already this morning, and it has a 4-time increase in cardiovascular death. So just a little image here of what we get when we're looking at your patients in the vascular lab. We can see this cross-sectional view of the arterial wall with the plaque built up along the wall, but this is what we see on ultrasound. We can actually see that plaque build up on the wall. So what do? Well, the provider sends them to the vascular lab for diagnostic testing and a full PAD workup. In our lab, we do ABIs and duplex. So we get blood pressures at the arm and the ankle, and we duplex. The duplex can give you a lot of information. The ABI is a basic exam. It tells you yes or no they have disease, but the duplex can actually tell you how severe the disease and where it is. This is just a worksheet, a PDF worksheet that we get after we get the pressures. And we not only get pressures when we do this, but we also get CW waveforms. And you can see from this patient's results that they had a normal waveform on the right at the ankle, and those waveforms on the left are bad. And then you can see that toe waveform is flat on that left foot. So what does all that mean? Well, we can tell as Dr. Melvin described earlier, we can get the pressure at the arm and the two pressures at the ankle. We take the highest pressure at the ankle, we divide it by the highest pressure at the arm, and we get that index. So we send this information. That index gives us a good baseline to surveil these patients, and it also is helpful in those patients who post-intervention can tell us whether or not the intervention was successful or not. So what do the numbers mean? Well, in our lab, we categorize these numbers into normal, mild, moderate, severe, and ischemic. Anything less than 0.35 is considered ischemic and tissue-threatening. We like to see those numbers in the normal range. So what are the limitations of the ABI? You've done this work, you've got the ABI, what are the limitations of it? So we can see here in the diabetics and patients with renal disease or kidney disease, they oftentimes have that calcific plaque along the wall of the artery. Well, that makes the ABI unreliable. Sometimes the ABI is just falsely elevated. Sometimes the ABI can be non-compressible. So what information do we need to further explain what's going on in the patient in the setting of these diabetic patients or these patients with renal disease? That's where the arterial duplex can come into play. So we can actually visualize the artery. We can see the plaque within the artery itself. We can also see at the top there in the center, you can see the stent. This is a post-intervention patient. We can actually see the blood flow through the stent, but this patient actually had reduced color filling in the stent with a peak velocity of over 400 centimeters per second, which would suggest that that's restenosis within the stent. So what do we do with this information? Well, we put it all together, and the velocity information, we can tell the doctor it's either occluded or it's stenosed. And we can draw this, we call this the stick man, and we can draw on there where it's severely diseased, where it's completely occluded, and we can hand that to the doc and say, here's your picture, go fix it. We tie it all up in a pretty bow in the conclusion, and our work is done. So what are the limitations to the ultrasound? We talked about limitations to the ABI. What are the limitations to ultrasound? Well, I spoke about the calcific plaque along the wall of the artery. It creates that acoustical shadowing. It makes it hard for the ultrasound beam to penetrate. Body habitus can be a problem, especially in the South where we like to eat, and we talked about the bad diet already. The further that ultrasound beam travels from the machine to that red blood cell, it has to travel back to where physics does its magic and we get this picture. So the further that pulse travels, the more attenuated the signal becomes. So if you see a report with limitations because of body habitus, it's likely because that ultrasound beam couldn't penetrate. So some of the reports from the vascular lab, you will see us talk about waveforms. We're all about velocities and waveforms, right? So you see here that normal waveform, triphasic, multiphasic normal waveform in an extremity. That's what we want to see because it's feeding high-resistant bed, all the way to the monophasic continuous abnormal waveform that's sometimes referred to as tardus parvus, and that's, hey doc, this patient needs to go get an intervention. If you see that waveform, usually we see those in our CLI patients. So talked a little bit about the ABIs and how we do those and what they mean. We talked about duplex, how we do that, and limitations. We're going to talk about below the ankle now. Historically, when I first started training and doing vascular ultrasound, the only thing we could tell the vascular surgeon was what the toe pressure was below the ankle. We would say, hey doc, it's greater than 30, that's predictive of healing. Less than 30, it's probably not going to heal. That was all we could tell them when I started about what was going on below the ankle. Well, now we have advanced duplex for foot hemodynamics. And this was really exciting to me when I first heard Jill Somerset from the Northwest talk about this, because this was something new on the horizon that we had never imaged in the foot. And when Dr. Lassar came back and said, hey, Tina, we're going to start imaging in the foot, I was like, we can't image in the foot. What are you talking about? We stop at the ankle. And he's like, no, we can do it. I'm going to get Jill out here. So we have been doing this now for 3 years, and we've learned a lot about it. We've learned what correlates, what might not correlate, but for the first time, we've actually started imaging these arteries in the foot because they are starting to treat some of these arteries in the foot, or at least give them some more information to know whether or not an ulcer on the foot is going to heal. So Jill described her methodology in calculating this pedal artery acceleration time. So you're measuring the time it takes for that red blood cell that leave the heart to get to where you're imaging on the foot. How fast is it getting there? So the lower the time, 68 milliseconds, means it's getting there fast. There's no blockages or significant blockages stopping it from getting there. The higher the number, the slower it's taking to get that foot perfused. So 68 is normal, 228 not so good. It's taken a lot longer to get there. So this is just some images of the ultrasound that we can see. The left lateral plantar, we can actually see the adjacent veins on the bottom of the foot with no flow in the artery, as opposed to the image on the right where the time is 270 milliseconds, and you can see that slow onset to peak of that waveform, indicating it's taken a while for that blood flow to get there. And then the image there on the left on the bottom is a normal waveform. I think that's the dorsal metatarsal. It's on the top of the foot. So that's a normal, high-resistant waveform suggesting that there's good perfusion into the foot. So what do these numbers mean? Well, when Jill did her study, she correlated these numbers to the ABI and came up with this interpretation criteria. So the lower the number, the more normal, the higher the number, the tissue threatening levels. And so that's what we're using in our lab to actually look. So time is tissue. I first heard this a few years ago, and I think it was Jill who I heard it from. But that is why we get our patients in quickly. We get their vascular ultrasounds done quickly, because we know that the longer we take to get them revascularized, the more tissue that they're going to use and lead to more amputations. And our goal is to prevent that. So this is the ultrasound crew. I tease Dr. Lassar all the time that vascular ultrasound is the heart of the practice, but we know that it takes every aspect of the team, from the referring providers to get our patients taken care of, get them in the office quickly, to get worked up, to get their ultrasounds done, to really make a dent in amputation in this area. Thank you.
All right, it's my pleasure to introduce Dr. Elizabeth Hartman. This, as we've seen so far, how to think about working up PAD in the office. We've seen how we work it up in the vascular lab and what we need to think about. What do we do with it at this point? And so Elizabeth Hartman has joined the VIC team. She, after completing her service in the United States Air Force, serving at San Antonio Military Center. She has her doctoral degree from University of Tennessee, Memphis. Her residency it was at University of Tennessee in Chattanooga here. And she did her fellowship at the University of Minnesota. She's certified in both general and vascular surgery. And I first met Elizabeth at Tennessee when she was a young resident of mine. And everybody wanted to have Dr. Hartman work with them because she had the most amazing hands any intern had. And I'm going to embarrass her a little bit, but she's truly one of the, a very gifted surgeon, and I'm very proud to have her as my partner. We will see Elizabeth Hartman next.
Good morning. Thank you. Anybody need to stand up and stretch? Get your stand hours on your watch. Anybody? Okay, fine. Okay, fine. All right. That was your opportunity to stretch. So I'm going to spend hopefully just the next maybe 10, 15 minutes. Yeah, maybe even 10 because we're a little behind. About claudication, limb dysfunction, and weakness, and when do we treat and how do we treat? So here we go. So the objectives, we're just going to define it. I know we've gone over it a lot today. Basically, classification systems, diagnosis, treatment. We have different type of treatment modalities. So what is claudication? There are actually kind of three types: neurogenic, arterial, and venous. I'm just going to talk about arterial, but classically, patients don't walk in and say, yeah, I have claudication. They walk in and say, my legs hurt. And so you have to spend time talking to these patients. And in fact, only about 10% of patients will actually have true claudication when they say, I get up, I try to walk, I get cramps in my calf or cramps in my hip and thigh at a certain distance, and then it stops when I rest. And it's classically intermittent. So like I said, only 10% of patients have this intermittent fact, Some patients come in and say, I heard it all the time. I cramp worse when I walk, but I'll even cramp when I'm sitting around and just sitting around the house. So you have to talk to these patients. A lot of these patients, I would say 50% or more, come in with atypical symptoms. My legs hurt, and they can't really describe it. Sometimes it's this weird phenomenon. One day I was in the clinic with Lacey. There she is. And we had this patient we thought was maybe a little crazy, and her main complaint on the chart was, I have bubble gum in my legs. And we were like, this patient we didn't know what to expect, but she sure enough had a 100% blockage, and she had a claudication, and she didn't know how to describe it. And that's how she described it, bubble gum in my leg. So these patients will come in and say crazy things, and we actually have to listen to them and do further testing to kind of figure out what's going on. This is more frequent in females when they come in with kind of weird complaints. A lot of people say, oh, it's just your arthritis, if you're a little old woman, but maybe it isn't. Maybe it's something different. Obviously, we've been beat this morning about the risk factors. Here they are. So mortality. So for claudication, what's the mortality? It's actually pretty low. And the mortality is actually related more to the cardiovascular coexisting coronary and cerebrovascular disease. So it's not so much mortality from their limbs, because we're just talking about claudication. We're not talking about rest pain or critical limb ischemia currently. But mortality from claudication is fairly low, and it's more so patients, it's a systemic disease as we're talking about. So they're coexisting other disease that's going to cause them more morbidity and mortality than claudication. So classification systems. Like I said, claudication it's a range. It can be non-lifestyle limiting, it can be lifestyle limiting, and it can be a range between those. There are two classification systems, one usually in Europe, the Fontaine, and that actually uses a subjective walking distance from the patient. So the patient comes in, you ask them, how far can you walk? And that's based on, can they walk more than 200 meters, can they walk less than 200 meters? There's also the Rutherford classification, mainly used in the US, and that's stages 1 through 3. So we have 3 stages that define classification: mild, moderate, severe. And classically, the Rutherford system relies on objective criteria. So absolute ankle pressures greater than 50 in someone that can complete a treadmill walking test. Not lots of our patients can complete a treadmill exercise or even just walking in the hall. So it's important to know this helps us to define when to treat these claudicants, because if they're in mild and moderate and they have uncontrolled risk factors, we might not be treating them with any intervention as of yet. So classification is very important. Now, patients come in with pain in their legs and they say, patient that comes in with 100% SFA lesion, you do your duplex, you tell the patient they have 100% blockage, they start freaking out. Okay, and we have to educate these patients about the natural history of claudication. So a lot of these patients will remain stable, especially if their risk factors aren't way out of control. 10 to 20% tend to worsen over time, and very few actually progress to acute limb ischemia. So they come in and one day and they have an acute blood clot. Usually it's a slow progressive disease. The deterioration, usually if it's going to deteriorate rapidly, it's going to happen in the first year. So say patients start to claudicate and it just gets worse and worse in the first year. A patient's been claudicating for 5 years, they have a pretty low likelihood that it's going to deteriorate fairly rapidly. And it's important to tell these patients because they're super worried they're going to lose their legs. And if we don't control their risk factors from the front end, very well may happen, but they need to know that claudication is just the beginning stages of peripheral vascular disease. So like I said before, the average claudicant is more actually likely to have an MI or a stroke than a major amputation. So how do we diagnose this? As Tina said, we do some imaging, but first of all, you have to do a very thorough history and physical. History takes time to coax it out of the patient, how long they've been having this, what are their actual symptoms, and physical exam, pulse exam, looking at their legs, taking off the socks and shoes. Physical exam can tell us a lot about where their lesion is. If they've got palpable pulses in their claudicant, you're probably going to end up having to do an exercise test because their ABIs are probably going to be normal if they have palpable pulses, but they could still be a claudicant, but you have to kind of delineate this. So treatment. There's kind of 3 treatment modalities: medical management, endovascular, and open. We'll kind of go through these. This is obviously a picture of a popliteal lesion. You can see the acute occlusion of the distal SFA, and you can see good collateralization. See that kind of corkscrewing? Those are the collaterals, and this patient has had this chronic occlusion probably for years to the point where they became lifestyle limiting, and then we intervened and were able to open it up. So medical management, we've talked about this before this morning. Number one, risk factor smoking. Got to stop smoking. Doesn't mean we won't operate on you if you're still smoking, but patients need to know that any procedure we do, outcomes are based on their risk factor modification. So controlling their diabetes. There's no point in intervening on a mild claudican if their sugars are 500, because whatever you do is just going to re-occlude in a couple months. High intensity statins, platelet inhibition. We talked about aspirin. We talked about other things. Walking, nobody likes to walk. None of our patients are athletes, right? When you tell them you have to go walk for 30 minutes, they're going to look at you like they've probably never done that in their life, so why should they start now? And then there are medications that can help, to include Pletol. So walking, we briefly talked about this. We'll briefly talk about it again. But like I said, patients, they've probably never exercised in their lives. And so they have absolutely nowhere to start. So you need to tell them minimum recommendations, 30 minutes a day. Well, most patients can't walk 30 minutes straight. I probably have a hard time walking 30 minutes straight. But walk until you have to stop, rest, and then get up again and just keep going, maybe for a total of 30 minutes 3 times a week. If they have a dog, tell them to go walk their dog. When the dog, if the dog needs to rest, you need to rest. It's usually only going to be in very motivated patients. They're not going to just start walking. It could be because it hurts, right? It hurts. And then you have to educate them on the pain. I tell patients all the time, the pain isn't actually making anything worse. They're afraid to walk through the pain because they think it's hurting something. It's actually not. It's improving that collateral network. And walking doesn't burn any bridges. There's really no risk to walking unless you walking in the middle of the street, get hit by a car. But walking, is not a risky business. So it's when we tell patients to walk, I'm not telling them I'm never going to intervene on you. Okay, I'm telling them start doing something that's probably going to help your long-term outcomes from your vascular disease. So endovascular treatment includes atherectomy, balloon angioplasty, stenting. We have lots of tools in our tool belt to help these patients endovascularly. We can cross very complex lesions. Some patients are claudicating and they have a 60% stenosis. Some patients claudicate and they have a very long segment occlusion that we can cross. So we have lots of tools that can help them, but we only want to use those tools at the right time. So, yeah, that's just another picture of, atherectomy, stenting, drug-coated balloons, and then open surgical treatment. When do we do that? I don't think I did that. Can you guys make that bigger? So open surgical treatment, very rare in claudicants because any open surgery you're going to do is more likely going to be an endarterectomy or a bypass on a leg. Those come with their own risks and mortality. Have to be put to sleep, they have a cardiac stress, and so if they have that coronary disease or they have that cerebrovascular disease, they're increasing the risk of MI and stroke just by trying to get them walking better. So we very rarely do open surgery on claudicants. These are usually patients that are younger. We started operating on them, they failed endovascular management, they have stents that we just can't open, and they can't walk, and they can't walk. Usually younger patients who are motivated, and this pretty rarely happens. So takeaways, risk factor modification, educating the patients on claudication, hopefully telling them, listen, this is not a life-threatening diagnosis, can be limb-threatening, but it sometimes takes a long time to get there, and the best thing they can do for themselves is stop smoking, take their medicines, control their diabetes, and we'll continue to follow them throughout their life. We can wait for questions after we have one more speaker, but thank you very much.
So we have our next speaker is Dr. Jay Jolly, who's going to be coming to us virtual, and we're working through some technical difficulties, so hopefully everything works well for that. Dr. Jolly is, his hometown is Chattanooga, and he went off to Baylor School and for undergraduate degree. His medical school is at the University of Tennessee, and did his internship and residency at the UT College of Medicine, and then went to Salt Lake City to complete his spine fellowship. So he is a board-certified orthopedic spine surgeon, and his predominant focuses are adolescent scoliosis, artificial disc replacement, and cervical spine. And we've talked about arterial claudication. I think it's important to understand neurogenic claudication, and then the differences, and so that we can figure out how to help patients in the best way. So I'll give you Dr. Jay Jolly.
Hey guys, this is Jay Jolly. Dr. Lassar is telling me to go. Let me ask, sorry about this. Bear with me 1 second. Okay, all right. Dr. Lassar says he can hear me. So I apologize. It sounds like we had a few technical difficulties, but I did make a very rudimentary PowerPoint presentation. So Chris, I'm going to assume you guys have that up, but I was asked to speak briefly about neurogenic claudication. So I'm a spine guy, evaluating patients in the office with spinal issues, doing procedures when necessary. So, when we hear patients who are coming in complaining of, painful walking, which is what Dr. Lassar wanted us to address today. So painful walking, of course, can be a number of things, but we try not to get tunnel vision. But when we hear painful walking, we, of course, think of spinal causes, albeit having to be mindful of vascular causes. So neurogenic claudication is a pretty broad subject, but it does imply lumbar spinal stenosis. And in the PowerPoint, I mentioned there is stenosis, of course, of the thoracic spine and the cervical spine. Those things are common, but they're not going to cause painful walking. So cervical problems, thoracic problems, they may cause spinal cord dysfunction and weakness, but they're not going to cause pain in the buttocks and legs. So I think that's important to remember as you're evaluating maybe MRIs that show cervical stenosis or thoracic stenosis. So neurogenic claudication would be painful pain in the buttocks and thighs, usually both when they are upright. They may not even have to walk. They could stand up and a lot of times reproduce pain in the buttocks and thighs. And then classically when they walk, they're going to get pain radiating usually into both buttocks and thighs. It's rare that it goes below the knees. So then, as you guys know, you've heard of radiculopathy. Radiculopathy implies there's pressure on one nerve root. So that's going to be more of a sciatica, where it's unilateral, goes down the buttock and usually below the knee. So it's usually one nerve root getting squeezed. Neurogenic claudication, it's stenosis squeezing the entire tube, the whole thecal sac in the lumbar spine. So in terms of diagnosis, evaluation, you ask them. And somewhere in the PowerPoint, you may see a shopping cart sign. So a lot of times these patients will say, hey, doc, yeah, the pain hits me in the legs. If I lean over, like on the shopping cart, if I'm at Walmart, pain gets better. So that's pretty pathognomonic for some stenosis in the lumbar spine. And then also the patient may say, hey, as soon as I sit down, boom, pain's better. And of course, I'm not the vascular expert, but there's some overlay there when you're asking these patients, and they may have a different response if it's a vascular cause. And we'll probably talk about that in the follow-up. But in terms of the examination, usually it's normal. They don't usually have profound weakness in the legs. Reflexes are usually fairly normal. Whereas again, if it's radiculopathy with a bad pinched nerve, yeah, they may have significant weakness. And then diagnosis, clearly we get x-rays looking for spondylolisthesis. That's commonly associated with lumbar stenosis. And then the gold standard would be MRI of the lumbar spine if they are appropriate for an MRI. And then also I mentioned before CT myelogram. So if the patient cannot have an MRI, CT myelogram is what we usually will order, and that's fairly comparable in terms of visualization of the neural elements. A plain CT, again, I think it's going to be somewhat helpful, but it's just not really that hard to see. And, you may see this in the presentation. I liken that to looking at an old black and white TV versus an MRI or a CT myelogram would be like, a brand new color digital TV. So from there, I will tell you this, if you're evaluating the MRI yourself and they say mild stenosis, and as we all know, all radiology reports are not created equal. And some will underread, some will overread. But if you've got radiologists that you trust their reads, if you see mild lumbar stenosis, it's probably not their problem. My ears would go up and think, maybe vascular. Typically, if it's neurogenic claudication and we think that it's real, the MRI is probably going to show more like moderate or severe stenosis, and with or with not associated with the spondylolisthesis. And what I would do at that point is, these patients are at no risk for paralysis. The spinal cord doesn't live in the lumbar spine. So, it's up to your comfort level. If you want to just refer them, fine. If you want to, if they're not very interested in interventional treatments, then, you could try physical therapy or chiropractics. This is going to sound anti-chiropractor and anti-therapist. I'm not, but it's really almost like you're checking the insurance box. It's not going to be that useful in treating their actual stenosis, but it's not a bad first step, especially if it's an older patient who's not very interested in needles or scalpels. But then the next line of treatment would be typically epidural steroid injections if the stenosis is moderate-ish. If it's severe, the epidurals don't typically work that well. We'll do those in the office usually, cheaper than the hospital. It takes 30 seconds. They're safe. They work, get the quarter out and flip it. They're kind of 50-50. But if somebody can get 2 or 3 or 4 months improvement out of an epidural, I think Medicare usually pays for up to 4 a year. Sometimes I heard 6. I confess I don't know the exact number. But I'll say 3 to 4-ish conservatively can be done. And then surgically, these patients are usually very happy if and when they undergo surgery for neurogenic claudication, also the stenosis. And that's usually outpatient surgery. Usually it's minimally invasive through these kind of very small incisions. even if it's a fusion, which usually you have to do for spondylolisthesis, now you're talking 2 incisions, bilateral that go a little bit larger. Still can be done outpatient many times, or overnight stay in the hospital or surgery center. Chris, I'm not sure how this is going to work, but that's the meat and potatoes of the presentation. So I'll be quiet, let you guys go.
So the way I can communicate with Jay is through text. So we're gonna figure this out best we can. And who are you? Tina Creek. Is she still here? We'll get her back. It's interesting to kind of see the play between primary care and the testing side of things. Now that I see Tina, we'll ask her the first question. So come on up. I think one of the things that people struggle with is we think this is an arterial problem, we think this is a venous problem. But if you send an order, so please check the venous, what do you do at that point, Tina?
When the order says, please check venous. So I guess we need a little bit more information. We need more info about what's going on with the patient, because a lot of times it's hard to know if it's arterial or venous. They present with the same symptoms sometimes, and then they could have mixed arterial and venous disease. So a lot of times we just need a little bit more information about what's going on with the patient. We would prefer to have indications or symptoms as opposed to please check for venous. Is that the right answer, Dr. Lassar? Thank you.
Questions out in the audience?
I'm going to preface my question by saying I am a non-smoker. So the running theme through the morning has been the cessation of smoking. So a lot of patients will substitute vaping for smoking. And my question is, physiologically, are they similar, the same? I don't know anything about vaping. So
I don't either.
There you have it.
No, it's no good. If you're not inhaling oxygen or good air, it's not the same. And actually, vaping can be more dangerous.
No, it's a good question, and we think that it's. I talk to patients a lot about the first is that they just need to have a will to do it. And then they start cutting back over the duration. So the number of cigarettes is what's important. So if they're a pack a day, 20 cigarettes a day, I tell them that I tell them to put it into a Ziploc bag, and the next week they drop it down to 18. But they're only allowed to have what's in the Ziploc bag that day. They don't have an empty pack that it continues. And so I don't think that the switching to vaping is going to solve the problem. They really have to first deal with the addiction that they have, which is reducing the number of cigarettes that their brain tells them to use. And then after they get down to about 3 to 4 cigarettes, I talk to them about the habit. So they get in the car and they get a cigarette, they get their coffee, they get a cigarette. And so you have to break the habit. So I think giving patients tools like that you can't just tell them to stop, because they won't, unless you give them the tools to do that. And then there's the medical therapy side, and usually it takes a counselor or some kind of coach. We do smoking cessation at VIC, and we'll have a lecture about that later today, and how we kind of think about it. So there's more to come on that. Any other questions? We have one over here.
So we talk about obviously smoking cessation, but is it not the nicotine which is actually causing most of the like vessel disease? Or is it actually the tar and the carcinogens from the smoke that's more damaging? Or the vape or whatever it is?
All right, give that back. It's the 2,000 chemicals that are created in the smoke. And when people take a cigarette puff, they instantly feel it in their brain because it hits from your lungs, which goes right back into the heart, and really 3 to 5 seconds later, it's being pumped into your brain and through your arterial system. And so the nicotine is what is where the addiction comes from. Okay, it's actually more addictive. Nicotine's more addictive than cocaine on a scale, but it is the aldehydes and all the different chemicals that are created in the smoke that actually damages the endothelium. And so that's the problem. So you have to deal with the addiction first, and then you deal with the habits, and then you try to get them to quit. Any other questions?
I think what Will was asking is, if you dip, is it just as bad?
You think that's what he was asking?
Is that what we're asking?
Because we're going to have them supplement, somehow step down, get off the carcinogens of the smoke to a different form maybe before we can get them totally stopped, right? Or is that not an
you take this one?
So I think the approach is if you're going for a pack a day, I think it's 20, to try to decrease it down to maybe half, and then look at the habit and ask them to sort of understand, what is it that you do when you get in the car? I turn the radio on and I grab a cigarette, and so making them wait maybe 15 minutes. Waiting 30 minutes, or I smoke on my way to work. Let's don't smoke on our way to work. And then as they come down, there's the substitute, you're right, they have the patches, and there's different medicines that can be used, but I don't think dipping is a solution to in that step down process. If that.
I don't see any other questions, and we're actually catching back up on time, so we got one more back there.
Throw. So, in addition to the significance of smoking cessation, where would you place the significance of using Xarelto in these types of patients?
All right, I guess it's back to me. Xarelto is a newer medication that that's been extensively studied. It's studied in antithrombosis events, so for DVT, PE. It prevents events in non-cardiac or non-valvular AFib, and it's been recently studied in the COMPASS trial and the Voyager trial about reducing the cardiovascular morbidity in patients with symptomatic coronary artery disease and or symptomatic peripheral vascular disease. So the Voyager trial is the peripheral, and the COMPASS trial is the cardiac. And the findings were that if you use that medication in conjunction with aspirin 81 milligrams, you can reduce the amount of cardiac MI, sudden death, decreased stroke, and for the leg symptoms, you can reduce acute limb ischemia events, and you can reduce amputation rates. And so it is very important in your symptomatic side of the cardiovascular spectrum. Good. All right. Let's move on. This is great. Good questions.